Right. Well, thank you very much, Sorana. Thank you for inviting me. My talk is going to be far simpler. So I know this is a medical retina talk, but there will be some surgical retina. I think it would be wrong to consider retina as being medical surgery, or retina is just retina. So we'll talk about the common conditions affecting patients with pathological myopia. So as we know, with pathological myopia, we have this axial elongation of the globe, where we, in some cases, we even get a dilation from at the back called the posterior staphyloma. And it does come in various configurations. We're not going to delve into the various classifications of staphylomata. But in many pathologies, in pathological myopia, the staphyloma is the primary cause of the disease. So this leads to complications at the vitreoretinal interface, but also complications at the RP Brooks membrane and choroid level. So looking at the vitreoretinal interface, starting from simple things, common things, so many of our patients will complain of floaters. And in actual fact, symptomatic floaters are often not related to PVD. They have a very syneretic vitreous. And you know, some surgeons might be tempted to do floaterectomies, but doing a vitrectomy in an eye, in myopic eye without PVD is fraught with problems, has a very high risk of postoperative retinal detachment. So that's something I personally try and discourage them from considering. Also, eyes with, which are big get a PVD at a younger age, and sometimes the PVDs are anomalous, so you could have what looks like a PVD, but it's actually a vitreoskitis where the cortex separates with the posterior hyaline membrane still being attached to the posterior pole. Increasing myopia is associated with increasing retinal detachment and various peripheral degenerations. So they do get common detachments with tractional breaks. The not so myopic patients can get round hole detachments without a PVD. You do get giant tears and macular hole retinal detachments. I know these are medical retina talks, so I'll be quick. So you would do vitrectomies for PVD detachments, buckles for non-PVD detachments, and those do reasonably well. We'll try and avoid silicone oil staphyloma eyes because you don't get a good tampon out. Now, moving on to the more pathological processes. So in a staphyloma, in a big eye, over time you can get traction. So you have the staphyloma on one side, which makes the globe bigger. You have contraction of the vitreous, which is usually tangential, and that combination can cause splits of the retina, which can be inner retinal splits, there can be outer retinal splits. Sometimes you can have a myopic macular detachment without a break, and you can get full thickness macular holes. So it's a diagnosis made with the OCT, and really, when you assess these patients, you really assess for any evidence of progression. So macular dysfunction progression is the most important thing. And apart from visual acuity, it's a good thing to assess near vision on a reading chart, because someone may have progressive symptoms, the visual acuity may be the same, but if you try and get them to read N5 or N6, they might not be able to do it. Because when we actually read, the macula will not just pick up single letters, but it needs to pick up words. So if the paracentral areas of the fovea are not working very well, you'll find that the reading speed really declines. And that should correlate with the patient's symptoms. And also, you need to assess any threat to vision. You need to see if there are any sort of full macular holes about to progress, so you should keep those patients under closer observation. So, so many patients are actually stable. You can watch them for years and without having to do anything too invasive with them. But if they do progress, if the vision is really under threat, then surgery is the only therapeutic option. And nowadays we tend to go for vitrectomy, we remove any sciatic posterior highlight that might be there, do an ILM peel, and we do gas. A recent modification is the fovea-sparing ILM peel, because we found that when we peeled ILMs in the past, many of these patients would develop a macular hole at the end, which is not a good outcome. So we now would try and preserve the central ILM. So by removing the perifoveal ILM up to the arcades, it allows the retina to become more redundant and flatten on the staphyloma without actually exerting any centrifugal traction on the fovea to open a hole. Macular buckles have been used. They may have a role in very large staphylomas or in failed vitrectomy surgery. There are actually quite limited designs. People can make their own using titanium clips and sponges. But there are risks with chronic compression of the posterior ciliary vessels and ischemia. So it's not really the first port of call. With macular degeneration, Adnan has already talked a lot about the pathology and the more kind of detailed features of it. But you can get atrophy of the RP and the choroid. With these solitary myopic CNVs, you can get them either in young adults, and you can get CNVs associated with breaks in Bruch's membrane. Older adults have a high risk of developing CNV anyway, which is more of the usual variety, and we treat with anti-VEGF agents that are actually licensed for this indication. Foster-Fuchs spots are actually areas of RP hyperplasia from all regressed CNV, as Adnan has explained, with a lovely talk. And sometimes you can get a simple CNV, a simple hemorrhage without a CNV. But it's the sort of thing that you should exclude. You should make sure that there's no CNV there, because sometimes you can get these type 2 CNVs that can look like a blood hemorrhage, but in actual fact it's a CNV. So you should do OCT angio to make sure that this is just a simple hemorrhage. And those patients do really well. Dome-shaped macula, it's actually quite a rare disease. In the first glance, it looks like a CSR, but these patients do not have the usual pachychoroid where the choroid of the macula is uniformly thick. They can have focal thickness, and they usually have thickened sclera, and that's probably the reason why these patients end up having chronic subretinal fluid. It could be a pathophysiological process similar to non-ophthalmos, where you have thickened sclera, and it probably alters the choroidal and RP fluid homeostasis. Unfortunately, it's very different from CSR. It doesn't respond very well to treatment, whatever you try, PDT or macropulse or anti-VEGF. It's important to differentiate it from CSR. You don't get the typical large bore halo vessel layers. You do get probably thicker choroid compared to many myopes. And the treatment options are very limited. It's a very short talk. Hope it was enough.
Wow, thank you very much for being so accurate. Any questions? I know coffee is coming, Paris, yeah?
I'm just referring to the last slide.
Okay.
With the ball maculopathy. My experience is that the results are very disappointing as well. I don't know if Adnan, you think that what would be your first option for both
nothing, observe, because actually they're usually asymptomatic. So usually if they're symptomatic, is one of two reasons. The RP is starting to atrophy over the top of the dome, in which case getting rid of the fluid may or may not help. It probably won't help the vision. Whether or not it stops the vision declining further is unclear and a long discussion with the patient. Or you missed CNV complicating it. So CNV can complicate the dome fluid. So if there's a sudden change in vision, absolutely make sure you're not missing a CNV complicating it. I think I've only attempted to treat... The problem with treating with PDT is twofold. People have also tried to treat with a plerinone with mixed observational results, because it does fluctuate. If you repeat the OCT, it goes up and down a bit. The trouble with PDT in myopes is, we learned this when we did PDT for myopic CNVs, that it may or may not get rid of the fluid, but causes a circle of atrophy in the RPE. So because these patients usually, but not always, are myopic, I'm pretty reluctant to do anything. And that's also the Alan Godrick's experience, who's the first person to describe this. He says, I've tried everything, and so I tend to sit on them and warn them about CNV symptoms. I've got patients where I followed up for only eye for 10, 12 years and remaining 6, 6, 6, 9. The fluid just sits there.
So I would like to make a question actually to both of you, because you both covered the topic, and actually perhaps to you first, Aidan. Myopic CNVs, you showed this OCT science of how we can realize that things are getting better in those membranes, but is it your primary test that you would use, the OCT, or would you like to go through FFAs or more FFAs? How would you tell whether it's a quiescent or it's an active disease and when to stop treating with anti-VEGFs? Well, both of you. First, you, Peter, maybe?
Well, that's already alluded to. Myopic CNVs tend to be very responsive to treatment.
Yeah.
They tend to need, the difference with age-related ACNVs is that it's a sort of condition where you can actually predict cessation in treatment. So you try and treat them until you get to an endpoint where the CNV is well localized and there's no evidence of any leakage. And then you observe them, and they will probably flare up. I mean, Adnan already.
So you go through an extra FFA. I mean, the point I'm trying to make is that sometimes you don't have subretinal fluid. So how would you tell that they're? I mean, Aidan made a point there.
So it's the combination of the two things: patient symptoms and the OCT having the subretinal or hyperreflective material, or not necessarily subretinal, outer retinal hyperreflective abnormality with a fuzzy border. Plus, patients will be symptomatic. That assuming there's no hemorrhage, again, it makes it easy. And that combination would drive your decision to start treatment.
Thank you very much. And how would you follow those patients up then? I mean, do you bring them back as you do with the AMD patients, or you just extend your follow-up period? How many injections would you give once you realize that it's stable? How do you do that?
So it's... So again, based on our UK trial that's then been mimicked in other studies and is part of the European product label, it's 1 plus PRN. That's OCT driven. Your primary retreatment decision is based on OCT, provided, and I really emphasize the need of really good OCT to look at that as the fluffy border and when it becomes distinct. So you use OCT to drive retreatment decisions. You bring them back on a monthly basis until it's anatomically stable. The definitive RCT, which got its phase 3 trial, which was PDT versus Lucentis with a primary endpoint at 3 months, with Lucentis given in the PDT arm at 3 months had 2 endpoints: treat to visual stability and treat to anatomic stability. They treating to anatomic stability on the OCT had excellent outcomes with 1 less injection than treating to visual stability. So OCT-driven retreatment criteria is the key. Once it's stable, don't inject, follow them up again in a month. If it's stable again, I then extend it to 2 months. If it's stable again, extend it to 3, and usually that's the end of that current episode, but it could flare up again at any time.
Thank you. Coffee time.
Good. Excellent.